breakfast, and there's a good reason for this. Some years ago, we were doing a program in Bangalore, and I was having breakfast with this German gentleman who I think was working for a pharma, and he said, and I told him, look, I need to go start the session. And he said, what's the great hurry in India? Everything runs late. I said, come in and you can time your watch with the way we run our sessions. And unfortunately, that obsession has led to this paranoid behavior on my part. Without further ado, let us start this session. Remember that this is a sponsored symposia, and therefore there are conflicts of interest. We are in Hall B. The topic is an insulin symposia. We have two amazing speakers, both of them doyens in their field. And the first person I'd like to call is Dr. Shashank Joshi. Needs no introduction, but on a personal note, someone whom I've learned so much over the years, who has grown fond of me, and I have grown fond of him, and someone from whom the whole country learns. Shashank?
So thank you, Krishna. This is a sponsored symposium, but you know the whole world has moved to basal insulin. Unfortunately, we still live in India and we are still stuck with pre-mixed insulins, which most people have now abandoned across the world. There might be a limited role for them, but I think what today I'm going to allude to is talk about the need for newer basal insulins. You know, we are nearing a century of insulin use, and what I'm going to allude to is the jury still out, or you know, is the verdict reached, and so on and so forth. So fundamentally, what I'm going to do is talk about an overview of which are the new generation basal insulins. We knew NPH, and from NPH we moved on to an insulin called glargine. Glargine truly was a game changer because the incidence of nocturnal hypoglycemia reduced by 33%. But the next generation basal insulins probably were one step ahead of glargine also. And probably they reduced the nocturnal hypoglycemia even better, probably to the tune of 1:10 to 3:10, so anywhere between 10 to 30%. They definitely have some advantages in the geriatric population, renal population. So clearly there is an advantage which is coming there. In the new generation basal insulins, currently we have two big molecules which are virtually conquering the world. In India, they have been available for the last 2 years. One is the U300 glargine, which is a completely different pharmacodynamic model compared to the standard glargine. And then, of course, we have degludec, which has been available either as a regular form or as a mixture. And therefore, we also have some data for these molecules which are head-to-head, because we need, today very few insulins have head-to-head trials, and we do have that. And as I told you that the U300 glargine probably has some unique advantages in high-risk populations. And most notably, the two vulnerable populations where hypoglycemia is at risk. One of them is the geriatric or the elderly population, and second one is the renal population. So this is what I'm going to allude to, and these are the three broad points which I'm going to discuss. We clearly need newer insulins, because if you look at the Indian data, and this is Dr. Ramchandran's data, and many other people have published this data, that clearly the insulin experience from patients from good glycemic goal has been a challenge. And clearly 1 in 5 patients with type 2 diabetes achieve an A1C less than 7% with insulin therapy. So it's a very old adage that you start somebody on insulin, the A1C will come down, but that necessarily does not happen. And one of the rate limiting steps of non-achievement of an optimal A1C with insulin has been hypoglycemia and automatic down titration, and second has been weight gain. So patients and physicians often autocorrect and underdose, undertreat. That's the big problem. And 2 in 5 patients with type 2 diabetes therefore reduce their insulin dose even after a minor dose of hypoglycemia. And unfortunately, this is a fact from India that more than 75%, 77% of patients who experience hypoglycemia after 6 months of their insulin titration or initiation discontinue insulin within 1 year. So
So this whole fear of hypoglycemia creeps in the minds of the provider and the patient, and therefore the whole story for insulin is lost, and which is why initiating insulin with the right basal insulin probably has become a center point. What is unique in U300 glargine compared to the standard glargine? Well, what is unique is that we knew that glargine was flat, did not have a peak. Later on, pharmacodynamic and kinetic studies showed probably did have a peak. So what U300 glargine is nothing but a compact depot formulation, which results in a very gradual, sustained release of U300 glargine. Its smaller volume and more compact subcutaneous tissue with smaller surface area, more gradual and slower release with the depot surface. And that release rate is proportional to the surface area. So this is something very, very unique. Very slowly, very gradually, in a compact formulation, we are getting a U300 glargine, which is a second generation long-acting glargine, with more even and prolonged pharmacokinetic and pharmacodynamic profile with a half-life of 24 hours. And the advantage of this U300 glargine or Toujeo preparation is, when you compare it head to head in pharmacodynamic studies and insulin clamp studies, it has a 20% within day variability when you compare it with degludec. So the within day variability is smoother and significantly lower by 1 in 5 or 20% head to head with degludec, and that confers it an advantage. When we look at the registration trials, the standard Toujeo trials or the U300 trials which were done were called and nicknamed with an acronym EDITION, EDITION, Edition 1, Edition 2, Edition 3, Edition Japan population, which is similar to the Indian population, and they studied anytime and nocturnal hypoglycemia, and obviously U300 glargine had lower rate of anytime or nocturnal hypoglycemia. And similar to that, the degludec had the BEGIN group of trials, which also had an Asian arm, and again they also had a lower rate of nocturnal hypoglycemia only from the registration database. So this is straight database, but it's not head-to-head comparison. So when we compare second generation basal insulins from the clinical pharmacological standpoint on PK/PD profiles in type 1 diabetes, the Toujeo insulin has lesser fluctuations with a better steady state within day variability and more even distribution of the pharmacokinetic profile, and also the within day variability is 20% lesser. When we look at trial level meta-analysis, head to head BEGIN group of trials versus EDITION group of trials, A1C reduction is similar, hypoglycemia benefit is probably a little advantageous with the glargine group compared to the degludec group. When you look at the real world evidence, which is head to head comparison, we have two data sets, the DELIVER-D and the LIGHTNING, which is more than 1,30,000 patients. When we switch to U300 glargine versus degludec, the glycemic control and reduction of hypoglycemia risk is severe, is very similar and something which we know. And therefore, there is always a need when you compare two agents for a head-to-head trial. And we have two such head-to-head trials, both from the sponsors. One is the BRIGHT study, another one is the CONCLUDE study. The BRIGHT study is the U300 Toujeo versus degludec, while the CONCLUDE study is U300 Toujeo versus U200 degludec. BRIGHT study, many of you all know this very clearly, was a multi-center, open-label, 1:1 randomized, active control, 2-arm, parallel group, non-inferiority study. Typically, people recruited over 18 years, diabetes more than 1 year, A1C between 7.5 and 10.5, BMI between 25 and 40. They were either using oral agents with or without a GLP-1 agent and no prior insulin use, and they were randomized to glargine versus degludec. And clearly you can see that A1C reduction was very, very similar. Body weight was very similar. What was unique and better, which was statistically significant, was the anytime hypoglycemia in the titration phase was better with the U300 glargine, and the confirmed hypoglycemia in the titration phase with the events also was better with the glargine. So the only difference which BRIGHT study got out, showing superiority of Toujeo over degludec, was the incidence of any time hypoglycemia confirmed less than 70 was 26% less. Any time confirmed hypoglycemia less than 54 was 37% less. Event rate was 23 and 43% less respectively. And event rate of confirmed nocturnal hypoglycemia was 35% less. So this was a very clear, significant positivity which was seen in the titration phase. We know titration is important because majority of the titration occurs in the first 3 months. A safe and effective titration is very important. Avoiding hypoglycemia in the first 3 months for basal insulin is a major predictor of long-term hypoglycemia risk, and most treatment discontinuation occurs after insulin initiation, especially due to hypoglycemia, and therefore we want a safe and effective or easy titration. So clearly the BRIGHT study showed us that for glycemic control, both the agents are similar by empirical hypoglycemia. Both can achieve active and adequate titration to achieve glycemic goals. The only advantage which U300 glargine offered was the hypoglycemia risk in the titration phase was clearly beneficial and statistically significant in the insulin-naive type 2 diabetic population. Conclude trial has been extremely marred because of a defective glucose meter. And we know that it was a trial of U200 glargine, not U100. U200 is not available in India versus glargine 300 in North America and Europe. It had around 1,600 participants. It had a titration phase with a glucose meter, then a maintenance phase with a glucose meter, and then when they realized their mistake, then they went to a functioning glucose meter, and they again had a titration phase, transition phase, and then they again republished the trial. And the primary endpoint was not met, and obviously they couldn't come to any major conclusion. There was no difference between both the agents, and that's something which we recognized, that it failed to meet the primary endpoint, and therefore the secondary confirmatory endpoints cannot be evaluated for statistical significance. And that is something which we all know. In fact, even in that study, which was presented at the ESD last year, clearly there was a significant diurnal symptomatic advantage with U300 glargine compared to degludec, but I would still not put too much to it. So if you look at the conclude study, well, the 200 degludec started with a 20% lesser dose. What can we conclude if there is no statistical interference? The rate of diurnal hypoglycemia should be considered as well, and how much of these results can be generalized is very uncertain. So if you look at head-to-head BRIGHT versus conclude, again you can see there is difference. BRIGHT is a non-inferiority RCT, conclude is a superiority RCT. Study population of BRIGHT is insulin naive, while conclude study population is insulin experienced. Primary endpoint in BRIGHT is the standard endpoint of A1C, while conclude was a confirmed symptomatic hypoglycemia during maintenance period 2 with the functioning glucose meter. And the top line results was non-inferiority was established in BRIGHT, while conclude failed to show superiority. So obviously BRIGHT is the only head-to-head study with second generation basal insulin analogs. When sub-analysis was published last year of BRIGHT study, one big advantage came out is the BRIGHT renal. In diabetic patients whose eGFR was less than 60, a statistically significant lesser hypoglycemia was seen, and that clearly showed better safety profile. And that's something which we know. We don't know whether there is increased hypoglycemia risk with degludec because it's albumin bound compared to U300 glargine, which is not albumin bound, and therefore is attributed to hypoalbuminemia, and that can increase the free fatty acid levels in type 2 diabetics, especially at night. So probably the low albumin we know has a strong positive correlation with diabetes or high A1C, and obviously if you look at head to head, probably the albumin can give us the answer. The other advantage which U300 gives over degludec is the elderly cohort, which was again presented at the ADA last year, clearly showing that people above 70 have a unique advantage with the 2GO insulin compared to the Tresiba insulin. And therefore, if you look from the BRIGHT sub-analysis, the A1C reduction in renally impaired is better, above 70 years is better, more subjects achieved glycemia without hypoglycemia, they were less anxious about hypoglycemia, and the treatment satisfaction was better. So summarizing, BRIGHT was probably the first direct comparison of glargine 300 versus degludec 100 with similar glycemic control and similar variability, but in titration phase the hypoglycemia was lower. Clearly in high risk populations, particularly renal as well as elderly, there was an advantage, and conclude study did not meet its endpoint, and the secondary exploratory endpoints still are challenges. So this was a summary of what's available from the published evidence. I'll be happy to answer any questions. Thank you for a patient hearing.
Thank you, Shashank. We'll take the questions together with Dr. Ramchandran. Next speaker is Dr. A. Ramchandran.